Snowitz, Desandra, Davis, Gould, Randall, Wallenstein, Tamaris, and then yours.
Thank you, Dr. Hibbs and Dr. Davis. I'm a third-year fellow at Stanford, and I thank you for the opportunity to share the results of the California Transport Cooling Trial. I have no conflicts of interest to resolve. This presentation will discuss the use of non-FDA approved device, Ticotherm Neo. We received 9 devices from Inspiration Healthcare UK for the trial. They had no role in the concept, design, analysis, or presentation of the data. Perinatal asphyxia is responsible for 23% of neonatal mortality worldwide. The incidence ranges from 1 to 8 per 1,000 live births. Moderate encephalopathy is associated with death or major disability in 35%, while severe encephalopathy is associated with death or disability close to 100%. Hypothermia has been found in multiple clinical trials to improve survival and neurodevelopmental outcome when initiated within 6 hours of birth. This diagram demonstrates the latent period between primary and secondary energy failure, where brain injury becomes irreversible. Hypothermia may provide minimal or no benefit if initiated after secondary energy failure, while earlier intervention may maximize the effect. This is a study we did. This is a scatter plot of NICU admit temperatures for infants who were cooled in transport in the year 2010. This data was obtained from California Perinatal Quality Care Collaborative, CPQCC. The desired temperature range is 33 to 34. Open circles are infants whose cooling was initiated by referral hospital. The filled circles are those whose cooling was initiated by transport team. 13% of the temperatures were below target, 43% were above target. 44% of the only 44% of the infants were in target. Given the poor temperature regulation, we designed the California Transport Trial. Our hypothesis was device-regulated cooling would improve temperature profiles as compared to standard practice. Our aim was to compare temperature profiles between both arms. 9 California NICUs participated in this multi-center randomized controlled clinical trial. Randomization was stratified by center in block sizes of 4. Study assignment was performed by opening a sealed envelope indicating the treatment arm. Transport team obtained written consent and opened the envelope. Sample size was based on Kendall's article, which had temperature trajectories. 50 patients per arm would provide us with 90% power to detect 30% absolute difference in percentage of temperatures in target range. Infants randomized to device arm were placed on a cooling blanket and connected to the device, Ticotherm Neo. The device recorded temperature continuously every minute. We obtained temperatures from this recording every 15 minutes for the analysis. Infants in the standard arm were cooled passively or actively. Passive cooling is when you turn off the radiant warmer or transport isolate. Active cooling is done using ice or gel packs. Infants in the standard arm had rectal temperatures performed by transport team every 15 minutes. Inclusion criteria were infants more than 35 weeks gestation who met the institutional criteria for cooling, and a decision was made to perform cooling in transport. Infants with lethal congenital or chromosomal anomalies, a decision to do comfort care, or refusal to consent were excluded. Our primary outcome was percentage of temperatures in target per patient, time to target temperature, percentage in target at 1 hour, percentage in target any time during transport. This is how we analyzed our temperatures. For example, here is the patient's temperature chart. Time 0 is when the cooling is initiated by the transport team. There are 13 temperatures, 9 of which are in target. So our primary outcome is 69% for this patient. This patient reached target temperature at 60 minutes. So secondary outcome, time to target temperature is 60 minutes. Did this patient reach target temperature at 1 hour? Yes. Is the patient in target any time during transport? Yes. 132 infants were assessed for eligibility, 31 were excluded. 101 infants were randomized, 51 to the device-regulated cooling, 50 to standard care. One infant in the standard care arm was transitioned to comfort care, and no temperatures were recorded, so was excluded from the analysis. 49 infants completed transport and were analyzed. 51 patients were randomized to device arm and completed treatment and were included in the analysis. Here are our results. These are baseline characteristics. The maternal characteristics were similar for both groups. Delivery characteristics were also similar for both groups, including mode of delivery and indication for C-section. All neonatal characteristics were similar for both groups except cord pH. However, the first postnatal gas pH was similar for both groups. The chronologic age at cooling initiation at birth hospital, at randomization, and at cooling center admission was similar for both groups. The length of transport when calculated from the time of arrival at the referral hospital to the arrival at the cooling center was longer for the device group. However, the total length of transport from the time of referral to the time of arrival at the NICU was similar for both groups. Here are our results for the primary and secondary outcome. The percentage of temperatures in target range during transport in the device group had a median of 71% with the interquartile range of 17 to 89. 50% of the patients in the standard care arm did not reach target temperature. So the median is 0% with the interquartile range of 0 to 52. 72% of the patients in the device arm had reached target temperature at 1 hour after cooling initiation. Only 20% in the standard care arm had reached target temperature at 1 hour. 80% of the infants in the device arm reached target temperature anytime during transport as compared to 49% in the standard care arm. Infants in the device arm took 44 minutes to reach target temperature as compared to 63 minutes for the standard care arm. P-value was significant in all 4 outcome measures. These are temperature trajectories for both arms. The top is for the device arm, the bottom is for the standard arm. Each line represents a patient. As you can see, many of the patients in the standard arm did not reach target temperature. Many came in and out of target, and there were several missing temperatures as well. We looked at other variables. There were no differences among the groups for length of ventilation, length of hospitalization,